My name is Dr. David Talan, and I'm here to present a research abstract entitled Clinical Pathway Using Dalbavancin Associated with Reduced Hospitalizations for Patients with Skin Infections. On this slide, you see my co-authors from the Departments of Emergency Medicine at Olive UCLA, Maricopa Banner, Johns Hopkins, and Truman Medical Centers, and other members of our Skin and Soft Tissue Clinical Pathway Study Group. The study is funded by Allergan, and the clinicaltrials.gov ID is listed on this slide. I'd like to recognize these other site investigators. In 2009, 870,000 patients were hospitalized for skin and soft tissue infection treatment in the U.S. with an average length of stay of 7 days at an estimated cost of about $5 billion. However, it appears that perhaps many of these hospitalizations could be avoided because the mortality and morbidity associated with these skin infections appears to be low. In-hospital mortality is less than 0.5%. In a study by my colleague and co-author Bill Mower, he found that when he looked at almost 3,000 patients who were hospitalized for skin infections, only 2.9% required the ICU, surgery in the operating room, or died. The reason for hospitalization is also important to consider. We conducted a study in which we looked at patients coming through emergency departments, found about 15% were hospitalized, and when we asked the providers their justification for putting the patient in the hospital, in 40% of the cases they said the only reason they were hospitalizing the patient was to administer IV antibiotics. So we think if you could decouple hospitalization and administration of IV antibiotics, perhaps we can substantially reduce avoidable hospitalizations. And in this time, recently, there have been some options for providing intravenous antibiotics, which include now single-dose, long-acting antibiotics, which would cover the patient over the entire course of treatment. So the study's hypothesis was that an emergency department skin and soft tissue infection clinical pathway can identify candidates for outpatient treatment following a single dose of a long-acting IV antibiotic, in this case one called Dalbavancin, among patients who would otherwise be hospitalized and reduce the initial hospitalization rate. These are our methods. This was a pre-post design study in which we compared hospitalization rates during two one-year periods. The first was when usual care was done in 2018, and then this was followed by a clinical pathway period for about a year in 2019. The study involved 11 U.S. emergency departments. Patients were included if they had cellulitis, wound infection, or abscess with an area of infection greater than 75 centimeters squared. And patients were excluded if they essentially had unstable comorbidities, infections that weren't treated with just gram-positive active drugs like Dalbavancin, or had other complications that might lead them to require ICU or operative care. And you see the exclusion criteria listed here. These exclusion criteria were developed by investigator consensus. During the usual care period, patients were taken care of as they usually would be. The providers knew there was a study, but the study was to look at outcomes of patients which they treated for skin and soft tissue infections. The providers were not knowledgeable of the before and after nature of the study that we're presenting. And then after the usual care period, the providers were educated about the next period where Dalbavancin would be given to each patient. They learned about Dalbavancin's indications and dosage, side effects, and also the nature of the clinical pathway, which was basically to include patients with the inclusion and exclusion criteria. And then our methods during the clinical pathway were to administer Dalbavancin 1,500 milligrams IV over 30 minutes. The Dalbavancin was provided free of charge. The providers could still decide on whether or not they thought the patient needed to be hospitalized. And for those who got sent home, In the clinical pathway period, the patients received a follow-up telephone call within about 24 hours, and then they had a scheduled follow-up visit at 48 to 72 hours after their index visit. For the usual care period, the providers, again, could decide whether or not they wanted to admit the patient, and then if they sent patients home, the follow-up was at the discretion of the individual providers. Our primary outcome was the initial hospitalization rate, which we measured by patient interview and by reviewing their hospital records. Secondary outcomes were length of stay, ICU admit, operating room surgery, outpatient visits, AEs, and certain patient-related outcomes, which you see here. This was designed as a superiority trial to test whether or not the clinical pathway significantly decreased the initial hospitalization rate. The study had an 80% power, an alpha of 0.5, and assumed an effect size of 15 percentage points to reduce the hospitalization rate from about 40% to 25%. And with those assumptions, we estimated a sample necessary of 161 participants in each period. These are our results. This slide shows you the characteristics of participants in the usual care and clinical pathway periods. You see there were 156 participants in the usual care period and 153 in the clinical pathway period. They were very similar in terms of age. Median age was in the late 40s. The most common type of infection was cellulitis, and then abscess. Some had characteristics of both. The most common location of the infection was the lower extremity. The lesion size is interesting. It was a little bit greater among participants in the clinical pathway period and was much greater than the minimal requirement for the study, which is also consistent with the indication for Dalbavancin's use, which is greater than 75 centimeters squared. 75 centimeters squared is about the area of this cell phone. 255 to 289 centimeters squared is about 6 by 6 inches, so it looks like an area something like this. About 20% met SIRS criteria. Most common comorbidity was diabetes, and the Charleston Comorbidity Index score was almost identical in participants between the two periods. So these are our results for the primary outcome, which was the initial hospitalization rate. In the usual care period, 38.5% of participants were hospitalized, and this was reduced to 17.6% with the use of the clinical pathway, a percentage point difference of almost 21% and a relative decrease of over 50% in terms of reduction of the initial hospitalization rate. These are secondary outcomes. We followed patients 44 days. We came up with 44 days because we assumed a typical treatment period of 14 days between IV and oral antibiotics in the usual case, and then a 30-day follow-up period. And we found when patients were followed over 44 days, the total hospitalization rate was still less in the clinical pathway group, 44.9% versus 28.8%. The post-initial care hospitalization rate was somewhat higher in the clinical pathway group. The length of stay was 3 days in each period. ICU admission was extremely rare, so this appeared to be fairly safe intervention and selection of patients. Adverse events is interesting. You see quite a few more adverse events were noted in the Dalbavancin group, or associated with Dalbavancin, than in the antibiotics used in the usual care period. I'll explain that a little bit later, but moderate and severe AEs were fairly similar. Missed work was the same, but impairment of work and non-work activities tended to be less in the clinical pathway period. Of course, patients in the clinical pathway period more often went home, so it's logical that you would expect less impairment in these types of activities. This study, like all studies, has limitations. This wasn't a patient-level randomized controlled trial. It wasn't a cluster randomized design. in this trial, the sites were uses essentially their own control group. In a randomized trial, you would have controlled for differences in providers and secular trends. On the other hand, a randomized trial would have been subject to learning by the providers if they saw that patients did well who got randomized to Dalbavancin. And a cluster randomized study is just very difficult to do on a budget. You need quite a few centers so that the centers balance out in terms of the characteristics. So we decided not to do that. The study wasn't blinded, and I think one of the consequences of that is that far more mild adverse events were ascribed to Dalbavancin because the investigators and providers knew that the patients were getting Dalbavancin. In randomized double-blind studies where Dalbavancin is compared with other shorter course, shorter duration antibiotics, you don't see differences in the rates of adverse events. We also assumed if the providers decided that the patients might need IV antibiotics, that IV antibiotics were necessary, but that, of course, is just an assumption, and many of these patients could have been treated with oral antibiotics potentially, and this study can inform that. Dalbavancin was provided free of charge. We felt we had to do this, and we couldn't impose charges on the patients or institution for the purpose of the study. But so you have an idea of the relative cost. Dalbavancin's cost is estimated at $4,604 for a single dose, which is what we used. The estimated cost to institutions for a 3-day length of stay is greater than that. It's $7,272. That's total over 3 days. We didn't carefully record the reasons for exclusion. We screened all patients with skin and soft tissue infections. We think this is a representative sample because of other studies we've done where on average about 15% of all those patients get hospitalized. And of course we then came up with exclusion criteria eliminating another 10%. And so our sample approximates the 5% of patients, or about a third of those who would be admitted, who now were candidates for the clinical pathway. So in conclusion, we believe that our study shows that a clinical pathway that included patient selection, a single dose of a long-acting antibiotic, and a 24-hour call and 48-hour follow-up visit significantly reduced the initial hospitalization rate for stable patients with skin and soft tissue infections and an infection area greater than or equal to 75 centimeters squared. We found that the initial hospitalization rate was reduced greater than half and absolutely by 21 percentage points. So I think this is an example where we can take advantage of alternative methods to administer intravenous antibiotics to reduce hospitalization rate for patients with skin and soft tissue infections. There have been other infections where risk stratification schemes have aided in the selection of patients who might be treated best and safest and as safely out of the hospital. And of course, we're familiar with those for community-acquired pneumonia, the pneumonia severity index. This is a study that was published last year by our group headed by Bill Mower, and I referred to this in the introduction. He looked at nearly 3,000 patients admitted to the hospital and looked to see if we could identify risk factors for bad outcomes. And the bad outcomes occurred in less than 3% of the patients and were lesions that required surgery in the operating room, ICU care, or patients who went on to die. These were rare outcomes, and they were identified by these 6 criteria: abnormal imaging showing, for example, osteomyelitis, the findings of necrotizing fasciitis, or a very deep abscess; SIRS criteria, diabetes, an infection that recurred in the same location, and failed oral antibiotic therapy; patients who are older than 65, and infections involving the hand. In our study, we used investigator consensus to identify and select patients for potential outpatient care, which to a great extent mimicked and included some of these risk factors. But we think that future investigations may want to focus on perhaps creating a scoring system like we use for community-acquired pneumonia to best select patients who can safely be treated outside the hospital. So finally, in selected patients, we found that compared to usual care, this clinical pathway may reduce cost and impairment of work and work-related activities, and future investigations should evaluate risk stratification schemes, as I mentioned, and clinical pathway use in other populations and settings. This slide shows the authors and their various financial disclosures. Thank you very much for your attention to my presentation.